Good evening, ma'am. If you are ready, you can go ahead with your
Yes,
presentation.
sir. My topic for today is pre-op evaluation, presentation, and management of a patient posted for removal of cancer head of pancreas. Pancreatic cancer is a highly aggressive cancer, so additional investigations should not unduly delay the treatment, and this will decrease the benefits of operative intervention. Regarding the clinical features of pancreatic adenocarcinoma, the patient presents with non-specific abdominal pain, jaundice, or either both, and unexplained weight loss and steatorrhea, gastric outlet obstruction due to tumor compressing the duodenum or stomach. It causes nausea and satiety. The risk factors are age, smoking, alcohol, raised body mass index, diabetes mellitus, chronic pancreatitis, and family history is a significant factor. It is also associated with familial cancer syndromes, inflammatory bowel disease, peptic ulcer, and periodontal disease. And regarding the pre-op stratification, peri-op management, we have to split as a risk stratification into a static testing and dynamic testing, and there is a role for enhanced recovery after surgery in perioperative care. It is very important in decreasing the length of hospital stay. And regarding risk stratification, pancreatic surgery, especially Whipple surgery, has a unique set of conditions, and it has 3 different anastomosis. And there is a role of multidisciplinary team is involved in this process, and it helps to determine the suitability for surgery. And regarding the static testing, preoperative NT-proBNP is a useful screening tool in identifying patients at risk of developing functional heart failure. If NT-proBNP is elevated, there is an increased risk of myocardial injury after non-cardiac surgery. And to guide further investigations such as echo and post-op troponin is also important. And we have to measure NT-proBNP in 65 years or older, and an age between 45 to 64 years with significant severe cardiovascular disease. And resting echocardiography is important in patients who has heart murmurs or cardiac symptoms, including breathlessness, pre-syncope or chest pain. And regarding dynamic testing, there is a role of cardiopulmonary exercise testing, which is well tolerated and non-invasive and cost-effective method to provide global assessment of cardiovascular, respiratory, and skeletal muscle systems. Selective cardiopulmonary exercise testing has predictive value in determining post-operative complications and length of post-op hospital stay in patients with undergoing intra-abdominal surgery. And dopamine stress echo is also done in patients who was unable to do exercise due to musculoskeletal impairment. And if it is positive, urgent referral to cardiology is important. And regarding enhanced recovery of after surgery, which is the ERAS protocol, which is a multimodal strategies that aim to loss of functional capacity after surgery and to improve its restoration. And this decreases the morbidity and enhanced recovery by decreasing the surgical stress response and effective pain control, early oral diet, and early mobilization. And regarding the pre-op strategies, preoperative counseling is important since this Whipple surgery is a major surgery and this decreases anxiety and increases post-operative recovery and discharge. This can be done by early mobilization, early feeding, and pain management in the form of multimedia information or eyelids. And smoking and alcohol cessation should be done 1 month prior to the pancreatic pancreaticoduodenectomy, which is also beneficial. And improving the fitness in the perioperative period and maintaining it also improves the outcomes. Exercising also will be beneficial if it is done preoperatively. And preoperative carbohydrate drinks should be given in patients without history of diabetes. And adequate thromboprophylaxis should be given for 4 weeks after the hospital discharge. Management of preoperative anemia. Anemia is most common in patients with undergoing hepatobiliary surgery and which is related to nutritional deficiency or anemia of chronic disease. Therefore, preoperative full blood count and vitamin B12 estimation and folate estimation, ferritin and transferrin saturation should be done, and iron supplementation should be given if ferritin is less than 100 microgram per liter or transferrin saturation is less than 20%. IV iron can also be given in the form of ferric carboxymaltose if there is an urgent need for surgery and to increment the hemoglobin rapidly. Folic acid and vitamin B12 supplementation can be given if it is deficient. Further, hematologist can also be referred. And regarding pre-op nutrition, pancreatic cancer patients are universally malnourished, so nutritional status should be assessed using a systematic screening tool. There is a tool called Malnutrition Universal Screening Tool, which is a must in short form, which is easy and rapid to use. And this can be done by supplementation with orally or either enteral nutrition, which can be started preoperatively, which is used for prompt implementation of effective nutritional interventions. And regarding the diagnostic investigations, we have to do the full blood count, which can estimate the normochromic anemia, thrombocytosis, or both. And in patients presenting with obstructive jaundice, there will be significant elevations in serum bilirubin, conjugated bilirubin, and total bilirubin, and estimation of alkaline phosphatase and gamma glutamyl transferase is also must. And the tumor marker CA19-9, it has a sensitivity of 80%, which should also be done, and it has a specificity of 73%. Imaging is important in the form of ultrasound, CT scan, and endoscopic ultrasound. And PET scanning to image the primary tumors, and it also used to detect the metastatic disease, which is also used in staging the disease. And regarding the jaundice in the periampullary cancer, which is the most common symptom in patients with periampullary cancer located near the Waters ampulla of pancreatic duct, it has a risk of increased post-operative complications, and jaundice is associated with increased incidence of insufficient post-operative renal function, sepsis, hemorrhage, liver failure, and risk of mortality. And jaundice is associated with retention of acids and bile salts. And in long term, this jaundice causes the ascending cholangitis and secondary hepatocellular damage. In case of interruption of bile flow, bile acids and bile salts can't inhibit the translocation and endotoxemia caused by gram-negative bacteria from the digestive tract, which will further create a pro-inflammatory state, and it causes the production of cytokines by activated macrophages and subsequent risk of multi-organ failure and coagulation disorders. And this Whipple surgery in turn increases the risk of post-operative complications, and thereby pre-op biliary drainage is important, improving post-operative outcome, and in severe cases also a pre-operative hemodiafiltration can also help to some extent. And regarding the intra-op strategies, effective analgesia in pancreaticoduodenectomy surgery is a must, and it causes good post-operative respiratory function, and compliance with physiotherapy is must, and mobilization and prevention of complication. But regarding the analgesic strategies, use of mid-thoracic epidural is widespread, which causes both intra and post-operative analgesia, especially in open pancreatic surgery. Thoracic epidural is associated with superior post-operative analgesia, which decreases the stress response and decreases the incidence of pulmonary or cardiac morbidity, which causes earlier return of the intestinal function and decreases the thromboembolic complications. For upper transverse incisions, epidural catheters can be inserted between the T5 and T8 root levels. Other options are patient-controlled analgesia with opioids, which is the most common modality used as an alternative step-down approach of analgesia, and in case of failed regional anesthesia. Also, there is another method is use of wound catheters and transverse abdominal plain blocks. Other alternative approaches are single-shot spinal opioid administration, which provide good analgesia for open and laparoscopic pancreatic surgeries. Intrathecal morphine and patient-controlled analgesia is also acceptable in the patient undergoing the liver resection. IV bolus ketamine and lignocaine infusion is also useful as analgesic adjuncts. Regarding the fluids, neutral fluid balance should be maintained to avoid salt and water overload, and restrictive fluid administration, it improves post-operative outcomes after Whipple surgery. Hemo concentration and raised lactate levels is used as a guide to fluid resuscitation, and balanced salt solutions should always be used. Mixed venous saturations can be used to determine the perfusion adequacy. Fluid management can further be complicated by epidural analgesia, and the resultant hypotension is interpreted as fluid depletion, and losses during formation of pancreatic and biliary anastomosis may go unnoticed. Central venous pressure monitoring is used as a guide to fluid therapy, and avoidance of hypothermia is important, and treatment of hyperglycemia improves the outcomes. Antibiotic prophylaxis should be used, and repeat dosing if there is a prolonged surgery. Depth of anesthesia monitoring is important in case of prolonged surgeries. Post-operative strategies. Pancreatic resection is associated with general risks that accompany the major surgery, including bleeding, chest and wound infection, thromboembolic complications. Mortality from pancreatic surgery is related to systemic complications, including sepsis, and mostly due to leaks from pancreatic anastomosis itself. Pancreatic fistula, which is most common, results from the anastomotic leak, which is difficult to resolve. It is diagnosed by amylase concentration of the drain output, which is greater than 100 international units per liter, which confirms the diagnosis. If sepsis is present, treat the sepsis and treat the malnutrition. Another complication is active monitoring of the development of pseudoaneurysm, so regular CT scanning is must. Active monitoring for hemoglobin drop and gastrointestinal tract hemorrhage is must. Post-pancreatectomy hemorrhage is also important, and it is best managed non-operatively via interventional radiology or endoscopy. Delayed gastric emptying causes discomfort and prolongs hospital stay. Imaging method is needed, which excludes the other causes such as intra-abdominal leak or collections. And this delayed gastric emptying is managed by long-term nasogastric tube drainage and correction of fluid and electrolyte imbalances, proton pump inhibitors, and nutritional supplementation. Pancreatic exocrine insufficiency, which is most common post-pancreatic resection, which causes fat malabsorption, and so supplementation with pancreatic enzymes like pancreatin is important. Management of diabetes. The diabetes mellitus in pancreatic cancer is different from the type 1 and type 2 diabetes. The diabetes in this pancreatic cancer rarely produces ketoacidosis as in type 1, and in these patients are sensitive to exogenous insulin with type 2 diabetes mellitus. And most common this total pancreatectomy until the islet cell transplantation, which is the final stage of treatment for this patient. Pancreatic surgery is often long and complex, which as a multidisciplinary professional team, which decreases morbidity and mortality. Your anesthetists play a key role in perioperative management, with ultimate cooperation between surgeons and anesthetists is vital, which in turn decreases the complication, enhances the recovery of the patient, and ensuring a positive patient experience. Thank you, sir.
Very good. Have you had a chance to anesthetize a patient for Whipple's procedure?
Not yet, sir.
Not yet. Okay. Usually your hospital has a very good gastroenterology department, and they do these surgeries
Yes,
very frequently, I heard. So definitely you will be getting a chance to witness such surgeries.
yes, sir.
What
Okay,
are the
sir.
approaches you know for doing the Whipple's surgery? Is it only open and laparoscopy or anything else recently introduced? Did you see in the papers
Mm.
news about pancreatic cancer surgery being done by a newer technique
Mm.
in the Apollo Proton Hospital?
No,
They're
sir.
doing it by robotic technique also. Okay? They
Oh,
have published
okay, sir.
a series of 21 cases done by robotic
Mm.
technique. So laparoscopy and robotic techniques only, they help the patient to undergo that enhanced recovery after anesthesia and surgery. So
Yes.
whereas open surgery, which is the conventional method done for a very, very long time and practiced even still today by some of the senior old type anesthetists, I mean surgeons, that involves a lot of hospital stay. Definitely the pain is more, and the exposure of the abdominal contents leading to electrolyte imbalance, hypothermia, and chances of infection are all very high in open surgery. The advantage of laparoscopy or robotic is that the minimal incisions, but there's a long learning curve, and people who get well trained and then by repeatedly doing only, they can do all the resection and anastomosis. It primarily involves three anastomosis to the jejunum. One is gastrojejunal anastomosis, another is pancreatico-jejunal anastomosis, and third is the biliary jejunal anastomosis. So these are the three structures which have to be anastomosed to the jejunum. And because of these three anastomosis, the risk of leak from these anastomosis is always high. Okay? And preoperatively, these patients may come into two categories, which are very important before we take them up and assess them and take up. Those with jaundice, those without jaundice. And if a patient has intense jaundice because of the tumor mass infiltrating at the ampulla flator and the point where both the pancreatic and biliary duct come and drain, is there any preparation needed for such patient? If his bilirubin is 10.5, because it's mostly conjugated because it's an obstructive jaundice, will he require any pre-op preparation before surgery?
Yes, sir. Yeah, CP or any stenting.
You can. That drainage procedure has to be attempted. Okay, so that
Yes,
with
sir.
intense jaundice, the morbidity and mortality is very high, and as you rightly said, the chances of renal failure very, very high. So usually what they do is they do a stenting to see whether they can drain the bile through the occlusion, and then reduce the jaundice level and then take up the patient for surgery. What is the role of neoadjuvant and adjuvant chemotherapy in before the preparation of the patient? When is it indicated? What is neoadjuvant chemotherapy and what is adjuvant
Before surgery, sir. Neoadjuvant is given before surgery.
before
Adjuvant
surgery?
chemotherapy is after surgery.
After
It
surgery, very good. So when is
decreases the
neoadjuvant therapy
disease.
is indicated?
It decreases the local recurrence of the disease, sir.
It also reduces the bulk. If the tumor size is
Yes, sir.
very huge, then you can
Yes, sir.
give an initial chemotherapy, try to reduce the size. Sometimes, because of the mass, they may be filtrating or very occluding the major vessels nearby. So in such situations, the surgeons would not risk to go and operate because the chances of a major hemorrhage is very high. So in such patients, they always advocate a neoadjuvant therapy to reduce the tumor mass and then take up the patient for surgery. Okay? So that point also has to be included. Otherwise, the presentation was quite good. I will just go to share my screen with you. So most of the points what you have said, I think I have already been there in my class lectures earlier. And, just try to